we're very fortunate to have Dr. Stan Chicouti giving our grand rounds this month. He is, well known to everybody, well known in the national, international community, in the advanced coronary space, and now especially in the complex valvular disease space. He's been a leader in Tmvr trials, with the core valve trial, with one of the highest enrolling centers in the United States, with Dr. Deeb as initially the co-PI, and now Dr. Patel, and has really made a mark and put Michigan at the forefront. This is now expanded into the mitral and tricuspid space with a lot of new trials, which we're going to hear a lot about. Stan is really a consummate physician. He knows so much detail about the medicine side of heart disease, and we always see that when we're on conferences together and learning not just about the technical aspects. And he's a very thoughtful physician and not always looking at just do procedures. So I've had a great pleasure of working a lot with Stan over the last year and a half, and it's become a lot of fun. So we're really fortunate to have you, Stan, talking about the advanced therapies. Please go ahead.
Right, get this open that way. So, first of all, thank you, Dr. Alawadi. That was extremely wonderful of you and humbling. It is really a great pleasure and an honor to present an august group of faculty and colleagues and friends. I could not be on this journey and be able to give this talk without mentioning Dr. Deeb that you mentioned. He has been a guiding light, a mentor. He pulled us up from a time where we were not doing anything, and really was an inspiration to all of us. So none of this would be possible in this institution without the leadership, guidance, and he knows when to step back of Dr. Deeb. So I want to make a special mention of that. Before I go in, I want to obviously talk about some of the conflicts I may have and take that into consideration. I do work I do proctor special cases for Medtronic when it comes to special sites when they need advice as to how to implant a core valve. I do some consultation, and I insist without compensation from Jena and Biotrace, the new companies, and I'll talk a bit about these. And then we get multi-center clinical trial support from the companies you see here. I also want to mention, this is a CME conference. I will be talking about certain devices that are not yet approved by the FDA. So valvular disease is a disease of the aging population. And as we know, the US Census Bureau data shows us very clearly that over the next 10, 15 years, the percentage of the population, or the number of patients over the age of 65 and 85 is going to increase. The baby boomers are going to get older, and they're not dying, thankfully. And we're going to have a lot of patients to look at. And if you look towards the graph on the right, even if you break it down into mitral and aortic valve disease, the numbers are going to continue to rise as we go into the elder space. Now, this is going to be kind of an overview, a panoramic view of the space. And I want to start with the aortic valve. I call it the valve that started it all. We are all very aware of this graph from Brunwald from 1968, though dated, still very pertinent, that this is a disease that is has a significant morbidity and mortality if left untreated. Once you have symptoms, and the symptoms can be settled. So the art and the skill of getting a good history in clinic is still very, very important. But once you have symptoms, if left untreated, you have a significant issue with survival significantly impacted. What we also know is that the surgical option is a wonderful option, and our surgical colleagues have done a wonderful job at taking care of patients with aortic stenosis. So you would think this would not have been a problem, that we had no issue with aortic stenosis. However, even in a county like Washington County, where we pride ourselves in having 3 very good institutions, the University of Michigan, obviously St. Joe's at the time, Dr. Gago and his whole team, and Pruitt, and the VA. These are 3 centers, and this is Dr. Galano's actual work, and I saw her on one of the audience. She collected these data and showed very clearly that even in spite of having good awareness, good clinicians, many patients go untreated with this disease. So there was an unmet clinical need, and this is where I call it TAVR revolution, but was really a revolution. If you talked to us in 1990s and said, we're going to have a device that goes in the aortic valve, just pushes the old valve out of the way, we would have laughed at you, but it was not going to happen. So this patent was very impressive. It has accounted for about $2 billion of money changing hands over the course of a few years. And somebody at Medtronic made the mistake of letting it go and giving it to someone else, and then bought by Edwards, and they had to pay them $1 billion back. But that's not for the sake of this this talk today. But the TAVR revolution, as I call it, began in 2002. We've all seen these cases in conferences when Alain Cribier implanted the first TAVR. They actually went transeptal and did it in an antegrade fashion. Our first U of M case was 28 April 2011. And as a result of these cases, TAVR began to develop as a potential treatment for a large and undertreated population. The landmark partner trial began in 2007. It was for inoperable and high-risk surgical populations with an Edwards sapien balloon expandable valve. And we have to give credit to the partner investigations for being forward-thinking and starting this process. Now, what we've seen, however, is as TAVR clinical trials have moved into the lower risk strata, patients have become younger and more prevalent. Low risk population makes 42% of all aortic valve stenosis patients. And even when you start to look at the partner from partner 1 all the way to low risk, your STS went down from 11.6 to 1.9, and the age concomitantly is going down from the 80s into the 70s. So we do have a wide range of population. I would also stress that it's important not to compare study to study when you talk about, for example, high risk or partner 2A, for example, with Certavi. The STSs are different. The ages start to change. So as the technology became more available, people began to become more liberal in enrolling in these studies, and also making sure realizing that we could do this. And there may have been some relaxation in the rigidity of who we enroll. So you can see that it is only in the low risk that we had the similar experience with both studies. So as we expanded TAVR to all patient risk categories, we've seen a dramatic growth. And in the beginning, we used to say, and this was something that was said in many meetings, that a rising tide raises all ships, that this is not just going to make TAVR very popular, but we're going to also increase the risk, the number of SAVRs that we see. However, in 2014, we noticed that something happened that broke this mold. So as TAVR continued to grow, around 2015, it was the summer of 2015, and Vinu Tarani presented these data first. We saw the first time that the number of SAVRs started to go down. And even if you add SAVR and CABG together, numbers are going down while TAVR continues to increase. Some of these data were also, I said Vinu Tarani, but also Joe Bavaria presented these data at EEX in 2018. So what we've noticed, as TAVR becomes available to a younger patient population, the doctor, and specifically the patient and his or her family, should consider the following when choosing between SAVR and TAVR. The patient age and anticipated life expectancy, the expected durability for SAVR and TAVR devices, and I'll go into some of that, the potential need for future interventions, and other clinical considerations favoring TAVR or SAVR that could be mitigating clinical situations. Based on this information, the choice of intervention should be a shared decision, and this is critically important, between the doctor and the patient, assessing different lifetime management scenarios and patient preferences. And I will go one step further, maybe be slightly controversial. I believe firmly in the heart team decision. So whether they come to a cardiologist or a surgeon, and that we are lucky in the space it doesn't happen, but even we should be also carry the banner for this philosophy. Everybody should get an exposure to both a SAVR and a TAVR option when they're being discussed in clinic. On the right, you see the life, excuse me. On the right, there is, you can see that the life expectancy, even for a 90-year-old, could be as high as 5-6 years. And so when you look at the 65 range, and there's a life expectancy of 10 to 20 years, you should anticipate that there's going to be 2 more interventions potentially in this patient's lifestyle once you do an intervention with a valve replacement with a bioprosthetic technology. So the priorities for me and for all of us in the clinic has now changed as we move from the low risk, as we move into the low risk from the non-low risk. When we started doing the early, extreme risk, high risk, or intermediate risk, our focus at the time, most of our patients, as I showed from the first graph, were 80 plus. They were tri-leaflet. They had low level of activity. So it was more a procedural success metric that we measured: mortality and stroke, PVL, conduction disturbances. How can we decrease the rate of pacemaker? But as we move into the younger population, there's more bicuspid or bicuspidity, as we sometimes like to say, bicuspid nature, higher levels of activity. Other priorities become more significant. Number one, the hemodynamics and the importance of patient prosthesis mismatch. The surgical specialties have shown us the importance of avoiding PPM and how hemodynamics affects durability and life expectancy. And then very important as we move into these large cages, coronary access. It's not just in the acute phase of coronary access, but how will a second TAVR or how will a second device inside a SAVR or a TAVR allow us to get into the coronaries in the case of an acute coronary syndrome. So the present now, and again, I'm not going to go into details of every study. We've exposed to these every day, but there's expanding clinical indications. Bicuspid valve is now approved. Dr. Deeb specifically has a paper coming out very soon that shows how well it functions, how well TAVR functions, and even in this subgroup of aortic stenosis. And we have longer term data, and we eagerly await the publication of the paper. Valve and valve is approved for high risk patients, and we might be even going to the intermediate risk patient. We've refined our large bore access techniques. Most of our cases, I would say 95% in our institution or more, are done by percutaneous approach. We believe in cerebral protection, although the data is not very robust when it comes to decreasing stroke. We have a surrogate marker of protection of MRI hits, which are significant decrease. And when our neurology colleagues ran rounds on the cardiology side, they all were big proponents of this technology. The minimalist approach, we rarely use general anesthesia. Most of it is local sedation. And I do anticipate as we get newer technologies because most of the reason we keep patients in is for rhythm observation. There are many companies now have these mini pacemakers that are the size of a dime that will go in the subcutaneous space that can be implanted at the time of the procedure if you have a high risk EKG features. And I anticipate in the next 5 years, we will be seeing same day discharge for TAVR. The next generation valve technology, we have third generation devices. We have a couple we're studying here. Lower profile, smaller sheets, additional skirt to minimize PVL. So do these valves work? I remember a paper, and I didn't want to show it, but it was Hartshell Schaff in New England Journal of Medicine, and it said something, editorial actually, it said, TAVR at what price? And they go on and on about the durability of TAVR, the risk of halt, and how this is not going to be sustained. Limited data exists on the incidence and factors associated with structural valve degeneration after TAVI and surgery from large scale, multi-center and randomized trials. A lot of registry data specifically Notion, the France registry and Italian registries suggest that these are technologies that will be very comparable to surgery, sometimes even better to surgical valves. And again, we can break that down as to why. Previous work, however, demonstrated that early generation, the early sapien, intraannular balloon expandable bioprosthesis had significant higher fibrate rates of structural valve degeneration compared to surgery, whereas newer generation annular valves have similar structural valve degeneration. So that even in the intraannular balloon expandable, we've seen an improvement. The core valve group analysis with supraannular self-expanding bioprosthesis found significant lower 5-year rates of hemodynamic valve deterioration or reintervention due to stenosis with TAVI versus surgery, and reported an association between this and clinical outcomes. So here's the data for the sapien. You can see with the early sapien data, the outcomes were worse than surgery. With sapien 3 and SAVR, the numbers are very, very similar. And what we elected to do in the SURTAVI trial, and Mike Redden just presented these data at ACC, two things came out, that in the randomized controlled group versus TAVI, there were more moderate structural valve degeneration, and there was more severe structural valve degeneration in the surgical group arm. Now, there was not one valve being used. There might have been an element of trifecta or mitral flows or other valves that we know have issues, and this has not been broken down yet. We also know that the surgical societies has some issue as the way these definitions, which I have on the right here, how you define moderate aortic stenosis as a valve degeneration and severe aortic stenosis, which puts some of the valves at a disadvantage because they have higher gradients at baseline, and we can discuss this afterwards. But as one thing which is very important, so this is in graph format, that there's lower structural valve degeneration TAVI versus surgery over 5 years, with a significant p-value here for this. But then I want to break this down into two different groups. In small annuli, there is a significant difference, but as we go into the larger annuli, the difference becomes attenuated. So again, kudos to your group that has really pioneered, and this goes from the early days of pushing towards root enlargement, the commando procedure, and now the procedure that Bo and all your colleagues here have really sort of pioneered and championed and made available to all of us. But I think it's critically important when we discuss SAVR, we need to discuss in clinic also the type of SAVR you are going to offer to your patients. So where do I see the future? We're going to see continued expansion of clinical indications, specifically aortic insufficiency in different disease states, earlier treatment of aortic stenosis. There's going to be a growing device competition. Unfortunately, even with 2 devices commercially available, we have not seen, there seems to be kind of a market price that has been set by the 2 companies. As new markets enter, as new players into the market, we're going to see a significant change. There's going to be a disruptive element. So just, I can speak freely here. We currently pay between $29,000 to $31,000 per valve. When the new third device is coming on the market, they have already offered us a price of $23,000 from $31,000. They also offer you a $3,500 rebate towards a pacemaker of your choice if the TAVI develops, if you develop heart block. So there is going to be a complete disruptor, and I will anticipate, just like we saw in the stent market, just like we saw in the ICD market, these numbers will start to come plummet down, making the cost effectiveness of this procedure even higher. And then I think the big thing we have to really focus on, and we need to lead this, is the lifetime management conferences. We do very well at having multi-specialists. I call them proceduralist surgeons, IC, imaging, heart failure, all involved in our conferences. Anesthesia, obviously, and I hate mentioning specialties because I miss someone and I get in trouble. Everybody's critically important. What we do not do very well, and I would like to get to a state, and Gaurav and I know, share this idea of maybe having patients and families logging into our conferences. Zoom has made this very, very easy, and probably even referring doctors coming into our discussion. So as we expand the disease states, and I'm very briefly go over this, there are trials now studying, and we have studies very similar here, patients who are truly asymptomatic, randomized in a 1-to-1 clinical surveillance or TAVI. To deem patients asymptomatic, they have to have a negative stress test. And then we have the early unload, which we have something here for patients in heart failure with moderate AS, and we have a similar study here. And I think a really important question, we have been firm believers that hemodynamics are everything. We used to have these debates, which valve is better. And I always, one of my arguments always was, just hold your breath, wait, durability will give us the answer. But I think kudos to the both companies. We're going to have a study that's actually going to look in the small annuli and compare 1 versus 1. And we'll see if there really is a difference between one or the other. And then as I branch out into aortic regurgitation, and we have this is, I think, a very interesting iteration of a TAVR valve. We have the Align AR study for Jena. This valve actually is approved in Europe, has a CE mark, and is also being used for aortic stenosis. Why is AI different? Because there are very many features what makes aortic regurgitation difficult from a TAVI tech standpoint. Number 1, you have large aortic sinuses and annuli. The aorta is dilated concomitantly in many of these patients. There is insufficient anchoring due to lack of calcium. And in the procedure, fluoroscopic visualization is difficult because of the regurgitation and the wide sinuses. The valve can migrate or embolize, and that's the nightmare scenario. You have residual AI because you don't have a nice seal. And because you're pushing and you tend to oversize these valves a bit more, permanent pacemaker rates tended to be higher in the early days. And this valve technology is actually very, very interesting because number 1, It has a design that anchors on the leaflets, not just the annulus. So it pulls the leaflets away from the sinuses, allowing us to actually have the space for future valve and valve technologies. You have a very wide, large cell design, so making coronary access not a problem. It has a stepwise deployment. It has deflectors that really allows us to, in a surgical fashion, to align commissure to commissure. And the controller mechanism fine-tunes the position and locates the orientation. So I want, and for the sake of kind of making more interesting, I have a case scenario here. This is an 85-year-old male with severe class 3 NYHA symptoms, severe AI on transthoracic and TEE. He had a history of type A dissection with an aortic valve resuspension and replacement of the ascending and hemiarch aorta with a 28 Vescitech graft in 2009. He did well. He has had an infrarenal aortic aneurysm with surveillance, but now presents with severe AI and was considered high risk. You know, the STS, if you look at the numbers, they look intermediate risk, but we have this frailty assessment, which he failed by walk. He had low albumin, and we have an incremental risk scores that add to elements that are not seen in the STS. And the heart team, but specific, this is a surgical decision, felt that this was a high risk patient. On CT, you also show some features that make this a bit maybe more challenging for our classic technologies. If you look that from the annulus to this kink, where the graft is anastomosed, is 31.7. So you could use an Edwards device here with little calcium to anchor. If you use a core valve that can be 43 millimeters high, this kink may actually push the core valve in or deploy in a way that is not favorable. Here are the measurements by CT. And again, we cannot do this without our imaging colleagues, both in the mitral and tricuspid space and in a TAVR space. Without imaging, we are nothing. And I always liken our imaging colleagues to the Sherpas. You can put the flag of your country, but unless the Sherpa takes you to the top of the mountain, you are not getting there. So we had a dogleg right kink evidence, which we discussed. And there's a newer delivery system for Jena, which is the XT delivery system. So we felt the 25 trilogy would give us 13 to 15% oversizing and would be a great element. Just to prove that this was not something we made up. There's the degree of AI seen on TEE. Here's the hemodynamics with an extracritical. You can see the wide pulse pressure and the small separation between the left ventricular and diastolic pressure and the aortic and diastolic pressure. Here's the baseline. Here's the baseline aortogram, which clearly shows what we saw on CT. You can see the severe AI and the dogleg right kink evident. So here's the valve going up. It's an 18 French system. We make sure the valve is loaded perfectly. You have a long sheet that goes to the sinotubular junction. And as the valve is brought up here, the sheet is brought back, which is something which we have to improve, is brought back to the ascending thoracic. And then you expose the first part of the valve. And at this point, we have a catheter that gets into each of the sinuses, but specifically the right and left. And we make sure that not only are we aligned appropriately by doing this arm sweep. So if you sweep towards the LAO, the middle valve should go towards the left, excuse me, towards the right. And if it doesn't, you're 180 off and you just rotate it 180. And then you have to make sure when you inject in the bases that you are in the base of the sinuses. So now you have commissures completely aligned. You're at the base of the sinuses. You're not pushing too hard. And you have a nice deployment, which is very well controlled. And you can see as it's being deployed, bang. It deploys very much more like an Edwards than a supraannular expanding. And here's the picture post. You can see if this were any longer, how it would have interacted here. And here's our hemodynamics. We always believe in hemodynamics. It is amazing to me that I proctor in many places and people don't do hemodynamics post. And I think it's a flaw. You tend to miss some of the complications of your procedure. And when things, and you miss things like LVOT obstruction that may happen from a suicide ventricle. And it makes your life so much simpler when there are issues happening post-op day 1 or 2, if you know the hemodynamics. Here's the echo post. And then at 1 month, this is the more impressive thing. The estimated valve area was 3.1. Most of these valves have a valve area of 2.7 to 3.1. And if we don't believe that because it may be an anomaly of LVOT measurements, the dimensionless index is at 0.77. So this is a very, very good hemodynamic valve. It will allow us, sinus width will not mean anything. Coronary heights will also be approached. So I think this, the next step for this valve, if it gets approved for AI, is to consider it for cases like the AI we see with LVADs and the AI we see with stentless aortic valves. Here's the study configuration. I'm not going to belabor this too much, and we move on to the next valve. That was the easy one. Aortic valve, specifically aortic stenosis, is an easy valve to treat. Morphology is not difficult, and you have an endpoint, mortality, which is very, very robust. These patients left untreated die, as we showed. If you treat them, they live. So you can easily show a difference. Mitral regurgitation is the valve disease with the highest prevalence in the Western countries. Functional MR affects 1.6 to 2.8 million in the US, and it's associated with a doubling in mortality in patients with mild or greater degrees of MR after myocardial infarction. The prevalence of moderate severe AV and mitral valve disease I've showed before increases with age. I am speaking to the experts here, so I'm not going to belabor this, but for those of us in cardiology, you guys taught us that there's a big difference. These are two separate disease states. Not all MR is created equal. Degenerative versus functional. Functional is a myocardial disease. You guys all know this. And the guidelines, European and American Heart Association, ACC, are very similar, that if you should wait for symptoms, and if there are no symptoms, you should wait for things like a fall and your ejection fraction, pulmonary hypertension, increase in left ventricular and diastolic volume. Dr. Bowling gives this talk, why do you want to be sick to get fixed? We need to maybe explore this in a scientific way to maybe push the envelope a bit more with these guidelines. And although surgery is the gold standard, this paper from the Cleveland Clinic showed that 50% of patients with severe MR are denied surgery for a variety of reasons, because they're deemed to be increased surgical risk. And you can see a lot of functional are treated medically and not approached. This is something we seem to be isolated in a cocoon here. We have a lot of outstanding mitral surgeons in our group who do fantastic work, and kudos to them. So we seem to have a skewed view of this, but in the real world, this is what we're seeing out there. And so the need for a catheter option became available. And, you know, surgery works so well because you can approach all these elements, the annulus, the cords, the leaflets themselves, repair or replacement can be done all at one go. The transcatheter options focus only on one element. It's either an annuloplasty, and there's a lot of issues with the annuloplasty technologies. You can do something with the cords, and you can affect the leaflets more in an Alfieri-like technique. So cords and Alfieri. So there are currently two devices. There are two technologies available for us that is commercially available. One is the edge-to-edge repair, which is basically a percutaneous Alfieri type intervention, or a failed by a current TAVR technology and a failed by a prosthetic valve. So I'll start with the edge-to-edge repair. MitraClip is approved by the FDA. We are in studies with this Pascal device. Pascal stands for pedal spacer clasp Alfieri, an easy way, an elegant way to make something look really cool. And the journey began with this Everest study. I know that Dr. Alawadi and Scott were involved in this, and were even in the paper coming up, which I'll discuss. And this paper was has a lot of criticism because it was a lot of disease states put into one group, and how the conclusions were made. And basically, although percutaneous repair was less effective at reducing mitral regurgitation than conventional surgery, the procedure was associated with superior safety and similar improvements in clinical outcomes. I mean, Ted did a good job at making the device look good, because anything that happens with surgery, he called a complication. So obviously it made surgery look less bad. But let's look at the two important things. Number one, mortality. There was no difference in the two groups. And the freedom from surgery, obviously, if you had a device that did not decrease the MR to the extent that you expected, many of these patients would have surgery. But once you had the surgery that was indicated, then the outcomes, the curves did not continue to separate. And this is the paper that Dr. Alawadi and when he was still in Virginia was part of. And you saw that it clearly shows that these are two different disease states, DMR and functional. But if you're even in a subgroup analysis, there seems to be some overlap when you look at these outcomes. So patients treated with percutaneous repair more commonly require surgery, as I said, during the first year after treatment. But between year 1 and 5, the follow-up was comparable with low rates of surgery for dysfunction going out. With either percutaneous or surgical therapy, either therapy is endorsed to do a period of MR reduction with both techniques. So it is very clear to say that a degenerative valve will be a benefit, but since the functional MR is a myocardial disease primarily, would this technology really have a significant impact over and above guideline-directed medical therapy? So there were 2 studies that came out very, very similar time. Obadia and from the French group, 304 patients with Lv dysfunction. So it's important to look at the criteria that are a bit different in the 2 groups, 15 to 40%, NYHA 2 to 4, with hospitalization for heart failure within the 12 months, and not eligible for mitral valve surgery. These were patients who were deemed to be high risk or extreme risk. The MR, again, is defined differently by the Europeans. The EROA was 20 millimeters squared, or regurgitant volume of 30 mils per beat. And again, they were a bit more lax with what they considered to be medical therapy. This is not what we did in the US with guideline-directed medical therapy, but real world. So whatever the primary doctors felt was appropriate, they treated. Randomized 1-to-1 in 3 centers, mitral clip or medical therapy alone, 152 in both groups. And lo and behold, there was no difference in the 2 groups. So we felt that Everest was kind of a stretch. This was more reality, and maybe this technology was that. And then there was the COAP trial. Again, this is Greg Stone, and you can argue that Greg Stone is a better trialist and does a better job at designing a study. It was an open label, parallel controlled, open label, multi-center trial, more patients, a bit more robust, moderate to severe MR, and severe 4+ secondary MR who remained symptomatic despite maximally tolerated GDMT, randomized them to 1-to-1. Now, the key here is the GDMT, and again, this stresses the importance of the heart team. No mitral valve clinic is complete without a heart failure specialist in the group. And when we had these patients screened, you would be put in the ringer. Why are they not on an ACE? Why are they not on an ARB? How much diuretic? Why not a spironolactone? So the GDMT plus resynchronization therapy had to be pushed before. And then on presentation, we all expected this to be a second mitra. And this is a press release from the time, and sometimes we cardiologists tend to overdo this. In a shocking success for the mitral clip, after years of gloomy predictions, sluggish trial enrollment, most of all the negative mitral flow. Last month, today, the long-awaited COAP results show the transcatheter mitral valve repair using the percutaneous clip in heart failure patients and severe MR not only reduced the primary endpoint of heart failure, but to everyone's surprise, also reduced mortality at 2 years. And this is again to make it even a bit more corny. There's an audible gasp, broke into applause, and even a standing ovation went up in the main screen. So both in mortality and in hospitalizations. And so if you compare the mitra, maybe they were different patients, and I'll show this and show you why they were different patients. If you look at the different characteristics, the EROA was a bit bigger for COAP. They tended to be more MR in the COAP group, and they tended to be less far gone from a myopathy standpoint, with LV and diastolic volumes being a bit smaller. So there might be a number whereby treatment might be too far gone, and they should be probably focusing more on replacement and support therapies like transplant or VAD than going down this road. Or what we need to also maybe investigate here is maybe a combination of both, and one does not preclude the other. We have the 3-year data that Mike Mack presented in this paper at JACC just last year. And there are a few bullet points that I think are critically take-home messages. Number one, optimal medical therapy is the foundation. Significant MR and symptoms despite medical therapy should be considered. It requires an excellent intervention and outcomes. This cannot be one and done. We have to strive to get surgical-like results in the procedure. Surviving patients request over-to-device treatment have a prognosis comparable to those. So you can try medical therapy first. It doesn't preclude a successful clip afterwards. Here's a simple case, and I'm not going to belabor this too much. You can see how imaging is everything. Just the torrential MR here, and under guidance. Again, shout out to Neil Duggal, who has done a brilliant job, and Andrew Harris and Megan Joseph. You can see us under control, and we still have some MR which we're not happy with. So we decide to implant the second device, and you can do up to two or eight, and we can down to 3, depends on the gradient and the area. And then after the second device is deployed, we're very happy with the degree of MR afterwards. And this is very, very common. Here is the Pascal device. It's similar, but it's not. It has some features where you have a spacer in between. The gripper is a bit different in its presentation, and also has a way of extending where it causes less entanglement in the subvalvular structure. We're part of this study, class 2D2F, and we have actually one next week. And if anyone was interested, you can clearly come and see us. That was the part that is easy. Now becomes the part that is really difficult. It's the annuloplasty. And I'm going to talk about, Carolon, you can have external annuloplasty. We're part of this study here. It's a very simple procedure. It's a right jugular access. You access the coronary sinus, only a Tmvr system, no need for DAP. The procedure takes less than an hour. It's conscious sedation, so you're awake, multiple implant sizes. And it tends to improve functional capacity in 4 to 6 weeks, improves the grade of MR. It's a physiological option to treat functional MR. It does not touch the leaflet, so unlike edge-to-wedge repair, that if it's not perfect, you take away the repair options many times to our surgical colleagues who do this invasively. This doesn't, and it maintains all future treatment options. You can still do an edge-to-edge repair percutaneously. You can put a valve replacement. There is no ICU for these patients. And here's a simple case. You can see the MR before. You want to confirm you have a distal anchor and a proximal anchor. It is in the coronary sinus, so you make sure the circumflex is not affected. And day 1 post-op, you can see there's not much MR. So I'm not going to belabor this too much because there's not much data. It's just something we have here, and we'd be happy to enroll to see your patients. Importantly, this also is considering patients who have lesser degree of mitral regurgitation. I bring this here because also it's close to us here, people, but this is the difficulty of this space. Cardioband, Millipede, many companies have designed annuloplasty rings. This is a device that's very elegant, and we thought was going to be available to us soon. They started a study. Here's an example of it being deployed. You can see under echo guidance again. What was interesting in this device, they had an intracardiac echo element in the middle of it. So hopefully at one point in the future, we also felt we wouldn't even need general anesthesia for this case. And here's a result of one of these cases. But just a few months ago, Boston Scientific decided to put this on hold. The good news is that we hear it might be coming back again in a different format, but we don't know what the financials of it. But again, and we've also played a bit with the cardioband for Edwards. We are in need of an annuloplasty device, and that story is still to be told. The other element we have to talk about is valve and valve, Tmvr. The valve and valve application, structural valve degeneration, both in every valvular space, is a major limitation of surgical implanted bioprosthesis. Reduced surgical MVR is the gold standard treatment. But however, in patients who have comorbid conditions, particularly the elderly, this may be difficult. And the transcatheter valve and valve has emerged as a very viable and alternative treatment options. And the data we have in STS and being collected is very, very promising. The Edwards Sapien valve can be implanted in a variety of formats. We started with transapical. There were a few sites doing transatrial, but now we do, the vast majority are transseptal. And there are treatment options for both bioprosthetic and mitral regurgitation. Here's another case which illustrates the ease, importance, and significance of this technique. A 65-year-old female admitted to us had a mitral valve and ASD repair in 2004. We do sternotomy. We had 27 magnet E's in 2011. EF declined to 35%, AFib, a flutter RFA. She was hospitalized in January with an EF of now 15 to 20%. and then was transferred to our institution with rapid decline and clinical status. The mean transvalvular gradient was 24 in acute renal failure, hypotension, and cardiogenic shock on pressors. Here is the unbelievable imaging, the quality that we get in the lab, but you can see that the mitral valve, it clearly has a pinpoint opening, and you can see the pressure acceleration going to it and the minimal regurgitation. Under echo and fluoroscopic guidance, we crossed the valve. We had, again, the heart team is important here. We had perfusion ready just in case something was catastrophically wrong. But you need to know the valve you have surgically. You need to know what you're implanting, because we position under fluoroscopic. You see there's no parallax, and I'm not going to delay this too much, but you can see how long under rapid pacing, and the pacing is done through a wire in the left ventricle, which you can see. And then once the valve is deployed, this took about 20 minutes. The actual implant takes about 15 to 30 seconds. Patient's hemodynamics improvement even started to make urine. Now, that is easily, it's valve in valve. The role of transcatheter mitral valve replacement has not yet been defined. There are unique anatomic challenges when compared to TAVR. Edge-to-edge repair has shown clinical benefit, but it's not suitable for all anatomies, as we shown. And there needs to be, as our surgical colleagues have shown us, there needs to be a platform that also gives us a replacement option in addition to a repair option. The challenges of Tmvr are vast. Delivery system, transapical versus transeptal, the complexity of an implantation in a transeptal fashion, the anchoring, instability, migration, embolization. How do we seal this annulus? The high screening failure rate. If a device has a 50 to 60% screen failure rate, it's not going to have a real functional effect in the community. Durability, we have to learn. Valve thrombosis are bigger valves, valve performance, stent fracture, stent fatigue, and then the very, very important LVOT obstruction. Again, the importance of an imaging partner, because we can predict the LVOT obstruction post-implantation, and we have numbers and parameters. And we've even taken this to a next level, that if you don't have the area post, you can even consider doing an alcohol ablation to increase that area if the septum is thick enough to be able to intervene on. The Tmvr considerations, and just to illustrate this again, pros, you have more predictable reduction in MR. You have a wider treatment of valvular pathologies, and it has a potential application for MAC, especially the thick MAC that sometimes is a nightmare in surgery. The cons requires, early applications require transapical. There are 2 transeptals, but the size of these transeptal delivery systems are in the 38 to 43 French. Concerns for LVOT obstruction. Here's a landscape. Many of these will die a natural death in the next few years. Here's a few of the 30-day clinical outcomes. We have some, we have Tendyne here, we have Intrepid here, and we're going to soon have Sophia. So we are extremely privileged, thanks to the leadership of Dr. Alawadi. We are seen as a good mitral site here, and the whole team here in general. And you can see that what was available. We have some experience with the Intrepid system. It's a 2-valve system. It's called because it looks like the moon landing. And this was initially a transapical system. And you open the brim, you come down, and then you seal the valve. And we are part of the Intrepid study. And again, we're very excited. Next week is a very important day because we have an edge-to-edge with a Pascal, and we have our first transeptal mitral valve replacement with this system. Here's a case: ischemic cardiomyopathy, EF 40%, severe MR. You can see the significant regurgitation. This is one of our early transapical cases. We're across the valve with echo guidance and under rapid pacing. You can see we pull back till the brim makes contact, and there's a pneumatic pump that delivers the valve, so you'll see it get extruded. And the valve is, this movement is indicative of the annular movement, but it always, for us cardiologists who are not used to seeing the valve in its natural state, always gives us a bit of agita and anxiety. And here's the post-procedure. We have had a lot of success with the Tendyne MVR, it's a transapical system. It really gave us the opportunity to treat MAC, and even though we have a MAC option for Intrepid, this has done a really, really good job. It involves tethering at the apex. Here's a design of Summit. And here's a CT look at what it looks like. And you can tether the leaflet, and we've even had to go back sometimes and tether again, but specifically it gave us the option to treat severe MAC. And then the holy grail for the space is the transeptal. There are, as I said, a few of these devices, Edwards M3, the High Life, Sophia, Intrepid, Alta. We have these two in our institution. So Tmvr has the potential to be another tool in the MV box. There are design challenges unique to mitral valve anatomy, including anchoring, and widespread adoption will require development of a transeptal approach. I don't want to sort of gloss over this, but coiled implants are also important. There's a limited indication as far, and you can see this is done in real time, purely fluoroscopic guidance. Dr. Romano is leading this effort and is doing a wonderful job at it. I'm sorry. So you can see in real time, and you can see this is a surgical technique, because if one of us cardiologists was doing this, you would all get a kick of seeing us trying to tie these knots. But you guys do it with one hand, and it's so elegant. I say that the tying of knots is the equivalent, is your manifold. We scare you with our manifold, you scare us with the tying of knots. The limitations of current repair devices, they are sensitive to mitral valve anatomy and physiology. You cannot test the true functionality of the device till full release, and there's limited options in case of recurrent mitral valve disease. So what we have to think about, and I'm just going to just sort of show this briefly, is we have tried percutaneously to replace what surgeons do. And maybe in the mitral space, that is not the option. We have to think of different ways of approaching this. We will look, there's a device here, and this is just, and it's again on hold because they had some developmental issues, but just to show that you have to think about the box, outside the box. And what this device, for example, will do, it creates a bevel that swings anteriorly during systole and creates a new coaptation zone. So this is one of many different things, but those of you young people who are super smart and thinking outside the box, just don't try to replicate what we do in surgery, try and think outside the box. And then to conclude, the tricuspid valve. You all know what the anatomy looks like. It is a very, very, very common condition. And even though it's very common, less than 0.5% of surgical cases involve the tricuspid valve. Even data also recently shows the significant benefit of treating the tricuspid regurgitation. Patients with TR and left-sided disease have worse outcomes. Many papers from here and similar papers from elsewhere have shown this. And it's a complex disease. It involves a plethora of risk stratification factors, demographics, clinical symptoms, comorbidities, other combined left-sided elements, and surgical characteristics. And then the severity, which we even argue about severity, annular size, the morphology, remodeling. And there's a happy point here where we should intervene. But many times, unfortunately, because I call it the neglected valve, we tend to see patients here beyond the point of no return. So again, I would give a plea to many of us in the community seeing these patients, please treat them early and refer early if clinically indicated. Parameters for regurgitation are well defined. And in fact, this is so complicated now that we've even created areas of what is called the massive and torrential TR. And the importance of TE and spending time during the TE to assess the morphology of the valve, to understand the degree of regurgitation, and multiple echo views are necessary for in-depth understanding of the tricuspid valve. Unfortunately, many times we have to repeat these because not much attention is paid to the tricuspid space. There's a complex algorithm, and none of these are yet approved. I don't want to overplay this, but I just wanted to sort of whet your appetite about what's coming down the pike for the tricuspid space. Both in the repair, edge-to-edge repair, in coaptations, in annuloplasty. We have an annuloplasty device starting soon here as well, and replacement. Edge-to-edge with the same devices, Pascal and Pascal Ace, which doesn't have the spacer. And here's an example with it. So again, imaging is everything. Now, many of these cases have pacing leads. Many of these cases have other devices. So imaging is critical. And we are now also, as of in 2 weeks time, May 8th, we're going to start also using Intracardiac Echo, which now has a 4D element and able to do multiplanar reconstruction also from intracardiac echo. So you can see, again, under the guidance of our imaging colleagues, we are told where to go. We confirm that we're in the right place, and we deploy these devices. There is a rationale for replacement. With repair, these leaflets, as I don't need to tell you, they are delicate structures. Imaging is challenging, as I said. Many times we've seen these patients very late, so there's large coaptation gaps, and there's a dramatic increase in RV after the reduction is complete. Tmvr is designed to eliminate no risk of RVOT obstruction and is applicable to most morphologies. So the wish list for a tricuspid valve replacement: treat all annular sizes, be transfemoral, have a size of a valve component that's 3-leaflet design. It should be atraumatic to surrounding structures, and this we've learned our lessons with this too. Should be fully repositionable and retrievable if possible. Allows for future valve in valve. And this is kind of the wishful thinking, but there is a valve that has kind of a trapdoor designed with it that to reduce the afterload of acute RV failure occurs. So if you go from severe TR to no TR, and LV is not normal, there is a kind of a way to open a bit the brim of the valve that allows some TR to still take place, and then you can close that with time. Here's the broad landscape again of what we're dealing with. We have a Vogue here, which is has atraumatic anchors. Depends a lot on imaging and a conforming frame. They have really, really good results with this. The EFS showed fantastic results, 0% mortality or intervention at 30 days. And we are now in the pivotal study and enrolling at a good clip. That's right. And here's the sort of the study. And then a valve that's also close to our heart, excuse the pun, is the Intrepid, because we happen to be the first to implant this in the world in a study. It's a different configuration, but you have an outer brim and you have an inner valve that is the functioning valve. There are cleats that allows you to be slightly canted, so you don't have to get all 3 cleats, and helps you in anchoring. And here's one of the first cases we ever did together. You can see that the severe TR in a class 3 symptom, 82-year-old patient. Heart team decision wants to proceed. The mechanism was a flail leaflet, so you can see how this would be difficult to try and grab if you were doing an edge-to-edge repair. CT is critical. We measure both the IVC and the access veins and the annulus to get an appropriate size. We've also learned from some past misadventure the importance of depth, and we're learning also the importance of pap muscles and other things. Here's a heart team, Dr. Romano, Dr. Bowling, and a plethora. So we start by doing an RV-gram. And then this is where this has to improve 25, 31, and 37 French dilators. And we introduce this behemoth of a sheet in the SVC, then bring it down to the RA junction. We are able to divert it under echo guidance and assess our trajectory. Because we are in the RV, we have a wire in the LV that we will use for pacing, because obviously you cannot pace in the RV with a device going across it. And here under echo and fluoroscopic guidance, we confirm where we are. And under echo, you open the brim, push down. So simultaneously echo and fluoroscopy. And deployment. Capsule is taken out with care. And here's the post. Very good result, minimal gradient. And on post of day 1, continued good performance. So the treatment is ever expanding. We have repair, annular reduction, valve replacement. It is important for us to study the role of these modalities, a role or in combination, and the prohibitive element of how we're going to pay for more than one modality at the same time. Ideally, there will be a toolbox that every company will give us, and that you capitate by the valve you treat, but not by the device you use. It raises the question, however, how do we train proceduralists? Can all of us be experts in all these different modalities as they become available? Imaging continues to be pivotal in all these procedures. And how do we compensate our imagers? I mean, this is an RVU-based system in many places. And an imager may be in the room for 2 hours to 3 hours, giving us the sight we need, but yet in the eyes of an institution has just that one TEE. So that has to be compensated. And I think there'll be a big role for 3D and 4D ICE. The heart team approach, I will keep stressing this, is critical. A patient coming to the University of Michigan should not get different mitral valve care, aortic valve care, depending on who he or she sees, but it should be a team approach to everything we do. What size valve, what surgical intervention you're doing, what TAVR you're doing, why, which TAVR we choose. However, like in every field in human history, technology will develop at an unremitting pace, and the victors will be those who adapt to it the best. So collaboration across the system for quality assessment and improvement. We cannot do this in a bubble. We have to be overseen. We have to parlay the patient population covered by the system to get first in men. I still believe we as an institution are primed to do this, to get early feasibility studies and all the pivotal studies here. And the institution has been good so far at really supporting us. This also will enhance our reputational score and retain patients in the system and enhance referrals into the system. Thank you. I'm sorry if I went slightly over, but I again, thank you for the privilege of being able to talk to you and maybe entertain some questions if there's any time.
Thank you, Stan. That was, I know, hard to give such a whirlwind of how many different things are going on in this space and span all the different valves. You didn't even talk about pulmonary valve, but there's so much going on, and I know you guys have done a lot with the pulmonary valve as well. It's really impressive. So, you know, there's obviously lots of specifics to go into, but in the interest of time, I think one of the big questions that seems to come out is, you know, an exercise in futility, right? We have these new devices that are now allowing us to treat a patient population that we never would see before. We wouldn't offer surgery to some of these patients for AS. We don't offer surgery to some of these patients with mitral and tricuspid disease. You know, and I guess I'm curious your thoughts on how do we help draw the line on futility? Yes, we can do these procedures. Yes, we can make an echo look good. But are there things in your mind that tell you for any given patient that we just shouldn't do it?
I think first, that's a very excellent question, obviously. I think number one, we have to be very faithful to what we're doing. And what I mean by this is collect data and follow it up. If we're seeing futility in 1-1 mortality is not what we expect, we can learn from what we're doing, number one. So I think openness and publishing our data is also important, because it also, whether you like it or not, when you publish your data and your results are publicly reported, you hold yourself to a higher standard. You're going to expose yourself. But more importantly, I think the discussion with the family and having subspecialties, like in the TAVR space and also in the mitral space, as you know, if someone has an oncologic condition or dementia or any medical condition that we feel that the treatment might be futile, we are partnered very, very closely with our palliative care group, and the goals of care are clearly defined. And whether if we think something is futile, the palliative care team is actually very good at helping us make that message to our patients much clearer.
Hey, Stan, can I ask you a question?
Of course.
Thank you. It's excellent talk. And, you know, we had those conversations before, because the partner trial, the pivotal trial, Notion trial, designed in such a way the surgeons are allowed to do anything they are comfortable with, which means we use different type of valves. We put small valves and without the root enlargement. The most common valve we used for the surgical valve was 21 and 23. We knew that narrowed the annulus significantly and decreased the valvular area by 50%. So I was not surprised that the PPM, the SVD, the degeneration of the valve was worse in the surgical group. And now, I mean, the huge swing to TAVR, now everybody's pretty much thinking of the TAVR for the first choice. What do you think about in the future? You know, we developed the new technique here with one type of valve, a good valve, surgical valve with the root enlargement, the upsize about 3-4 valve sizes. Do you think that will swing the way backward to the find the appropriate patient for for surgical valve replacement, or will be just like PCI first and then CABG? What do you see the future of surgical valve replacement?
I mean, I agree with you completely. What we see in some of these studies are valves that were too small, valves that, I mean, I hate to say this in the surgical arena, but we did not do a good job as a medical community of following valves for many years. So even in the trifecta world, for example, we still have arguments if trifecta is a good valve or not. But you have elegantly shown, and even in what we presented in core valve, a large annulus gives you good hemodynamics, gets you good valve. So to answer your question and not beat around the bush too much, I fear right now that the horse is out of the barn, that TAVI is here and is here to stay. I think you and people like you have to, first of all, convince your surgical colleagues that enlarging the valve with your technique is important. We have to have consistency in our institution, and then we can be sort of disciples going outside of here. Number two, once you have those data, we start to publish those data, and we can propensity match to our to what we do in TAVI. And once you have that kind of data available, I think I would suggest that this is something that the NIH might want to consider as a new study. No company is going to fund this, but the NIH may fund this.
Mm-hmm.
Yeah, I do think that's for the patient's best interest.
Yep. That's a
I
good,
believe so
good,
too.
question.
Yeah.
I think Dr. Pinsky has a question. Maybe this could be the last one. I know people have to get to clinical responsibilities.
Yeah, just to real quick. First of all, remind me how many clinical trials we have here. It's a big number.
It's a very big number.
More than a dozen. I couldn't count them all. Yeah, which is fantastic. We're probably the only place that has so many. So tour de force. Then a question about the mitral valve, Tmvr. You know, it's different than the aortic. What keeps the valve from not eroding into this continually pumping ventricle? Like, is there a mechanical issue with erosion just because it's in this pounding zone?
The answer, we don't think so, but we don't have long-term data yet. Understand that most of these devices are nitinol, so there is a give and take. It's not a continuous outward force, so there's conformability. We see these in dynamic CTs. There is a movement with these valves, and even fluoroscopically you see. But more importantly, with CT, you can see how the valve conforms. And that is the theory, that it doesn't really affect it because it allows the annulus, because as you know, the annulus has an important role even in diastolic filling of the heart and how the heart functions. So I don't know the answer, David. None of us do. We're just going to have to wait. I mean, the companies have done a good job, and biomedical engineering have done a good job at predicting models that this is not going to be a problem. But between the promise and the delivery, sometimes there's a big chasm.
Great, thank you. Great talk.
Right. On behalf of cardiac surgery, Stan, we really thank you for being a part of us. You really are part of us in many ways. So we appreciate you giving some deep insights and show us where this field is going. It's very exciting. Thank you again on behalf of all of us.
Thanks.